Welcome to another Omega Matters with Dr. Kristina Jackson and me, Bill Harris. We are here to talk about all things related to omega-3 and sometimes omega-6 fatty acids. We are pleased today to have guest Mohammed Al-Khalil from Newcastle upon Tyne. He's an interventional cardiologist, trained originally in Damascus and then in Belfast, Northern Ireland. Did his cardiology training in Toronto, I believe, and then he went and got a PhD, for crying out loud, in Oxford. So we have a very well-educated, unusually well-educated cardiologist to join us today. Our topic is going to be omega-3 and bleeding. And we're going to start by asking Dr. Khalil to tell us what got him interested in the whole omega-3 story, as well as digging deeply into why bleeding was also of interest. So welcome.
Thanks, Bill, for the nice introduction. You could call me Mohammed, as I said, it's not a problem.
Okay, thank you.
Yeah, well, it's a fascinating story, actually. As you said, I'm an interventional cardiologist. We deal with coronary artery disease, with fat accumulation in the coronary arteries, lipid accumulation, and it's the cornerstone of what we do. And, as physician, we don't like putting stents in people where they don't need it. We try to prevent this from happening. And I think we have to dig into why people are developing coronary artery disease. When I did my PhD in Oxford, or they refer DPhil, this is the actual what they like it to be called. So it was about lipid and how we characterize patients, trying to understand a bit more about how we could tailor treatment. So we know there are different pathways for patients to develop acute coronary syndrome, heart attack, and we understand that a bit more. One mechanism could be related to platelet thrombosis. The other mechanism could be related to inflammation. And the third mechanism could be related to lipid-lowering treatment. Now, we know historically that statin reduce event rate. And despite patients being on optimal treatment, so they are on the right drug, they receive the right treatment, they still come back with event. It's not a small event. They come back with a 20% over 5 years. And this is despite all stuff we do inside and outside the cath lab in hospital. So we need to find a way to try to treat patients better, find a different pathway. And over the last few years, we have seen advance in understanding of this. And one of the main things comes up is the triglyceride story. And subsequently from there has been some drugs developed to reduce the triglyceride. Now, the results haven't been consistent. We've seen that with niacin, we've seen that with fibrates. But there's one who stands out for sure, although it's been labeled as a triglyceride-lowering treatment, but I know that the mechanism is far beyond this, and we could talk about this, and that was Vascepa, which potentially is basically a highly purified omega-3 fatty acids. And when we looked at the data coming from the REDUCE trial, it was surprisingly out of proportion to what we think the mechanism of Vascepa was, and that's what triggered a lot of people to think, well, there are other pleiotropic effects, there are other mechanisms, and people propose anti-inflammation and antiplatelets, and obviously plaque stabilization, all of this. But this is what triggered me, because when you look at the data from the REDUCE as well as from the other studies, there's a slight increase of bleeding when you look at this. And what I thought it's a single study looking at a certain cohort. And what we need to have, obviously, the event rates are relatively small. And one way around it is to try to collect all the studies published on this subject and try to think about whether actually the bleeding risk, is it actually present? Is it meaningful to patient? Or is it something that we have just to tell patient, look, there's a slight increased risk, but probably the benefits outweigh the risk. And that's what triggered the whole story about looking into omega-3 to see whether can I benefit my patient by advising them about this particular subject.
Yeah, great. Yeah, and bleeding, of course, can you kind of rehearse the history of bleeding in omega-3? It kind of goes back to the Eskimos, I believe.
Yeah, yes, you're right. Actually, if you look back, I think the data comes back from 5 decades ago. I think there's a paper in Lancet talking about the increased bleeding. Bleeding time is higher in Eskimo or Inuit patient populations, and they've done a lot of tests, and particularly bleeding time is higher, and they link this with the high fish intake, dietary fish intake. That this is what exactly triggered that. Honestly, omega-3 fatty acid might be linked to increased bleeding. Now, is that clinically relevant in terms of, do our patient are high risk of bleed? I think it's unlikely, and that what we're going to show, maybe discuss later. But basically, it drives a second mechanism of how omega-3 work, because everyone believes that omega-3 only targets basically your triglyceride. It's a lipid lowering treatment. But what this adds is basically there's a second mechanism here we're talking about, which probably is an anti-platelet effect.
So you're basically looking at this bleeding question as kind of a two-sided thing. Too much of it could be bad, but maybe we need a little bit more anti-platelet, or we need a little thinner blood in general. And the omega-3s might be providing that. So you're kind of looking at it as a benefit in a way.
Yes, correct. Exactly. This is the whole idea. Is basically I'm trying to see, so the benefit comes in from omega-3 when you look at particularly a reducing trial. It's not purely related to lipid lowering. We think there's a second, we think there's a second mechanism.
Yeah.
We need to quantify what exactly this mechanism, and we need to see, is that has any detrimental effect on patient, or does that actually help patient? Because obviously patients who receive stents, or even patients who had bypass surgery, they benefit from having a blood thinner on board. And
Yeah.
this is what we've been historically doing. And we see whether omega-3 contribute to this mechanism.
Yeah. So the paper we're going to talk about, you recently published, is a meta-analysis. You want to tell us what a meta-analysis is?
Yeah, so as I alluded to, so basically, when we have a randomized trial or a non-randomized trial, we look at a cohort of patients of relatively a small sample size. When I say small sample size, we're still talking about thousands of patients.
Yeah.
Now, when we want to detect a small or a rare event, are we talking about 1% or 2%? In order to us to objectively assess the risk, we probably need more than a few thousand. Are we talking about, hundreds of thousands of patients? And this was the aim of the meta-analysis. So basically, it's a collaborative effect where we collect the data from all the published studies and synthesize the evidence and try to find what's the benefit and what importantly is the risk that was reported in those studies, and try to come with an objective, a more definitive answer to certain questions, such as, is there a bleeding risk with patients who are receiving omega-3 fatty acid, which we can't address it in a small, relatively single study.
Yeah.
We have to collect a bigger sample size.
How did you define bleeding risk in your study?
It was a very difficult thing to do, to be honest. But one of the things we have to take in, because this was a study level meta-analysis, so we couldn't get into, despite our efforts. So what I've done initially is I get in touch with all the leading authors from all the published papers to try to get the individual data, because that will be the best evidence. Now, we did have some responses from a couple of leading authors, and they were happy to share this. Some people actually shared with us the data, not all of them. And unfortunately, if you have an incomplete data set, you can't go ahead and say this is an individual patient meta-analysis.
Yeah.
So we have to accept this is a study level meta-analysis. So the way around it, we restricted the definition according to the way the studies define it. But what we've done over there is then we categorize the bleeding according to the way they define it. So for example, if it's a GI bleed, we looked at those differently, and we tried to collect all patients who had GI bleed from different studies. If they have an intracranial bleed, the same thing we've done it. If they had a hemorrhagic stroke, the same mechanism is done. And this is the way around it. It's a limitation, but actually it will provide us with a very accurate assessment of how omega-3 will affect or won't affect the bleeding risk in patients.
Yeah, great. So can you summarize for our viewers, kind of how you did the study and then what your main findings were?
Yeah, so what we've done basically, we looked at all the search engines, and we do have a very recognized search engine where all the published data are stored. And we looked at the main one like Medline, PubMed, Cochrane database, a lot of search engine. It requires a lot of man effort, so I have to thank my colleague, who's the first author, Mustafa, who went through this with a lot of guidance from myself and my colleague. But at the end of the day, when we set up the search strategy, we had to look at certain terminology, so we will ensure that we don't miss any study which could be relevant to what we're trying to answer. And we set up a very strict, but open also, strict criteria in terms of what study we need to include. However, the search criteria was very liberal. So as I said, I don't want to miss any study. but I want to get the right study for my analysis.
Mhm.
So we looked at every study that, looked at atherosclerosis and on lipid, triglyceride, omega-3, EPA, DHA, lipoprotein, antiplatelet, anti-thrombotic bleeding. So you could see it's a very, very wide search criteria.
Mhm.
And from there, we were able to identify more than 28,000 database.
28,000 articles?
28,000 articles. And from there, we had now to filter out the
Yeah.
one which are not relevant. And this obviously took time to go through all this. Eventually, we were able to down the number into 666 articles. And then we have to go through one by one to manage to find 11 studies which was relevant and exactly to answer our meta-analysis. So it's a lot of work.
Wow.
It's not a simple work. It's a lot of work, but I thought it would be worth the effort because we have to answer that question.
Yeah. Great. And so you found 11 studies, which are all randomized controlled trials, correct?
Correct. All
And
randomized controlled trial. All studies had more than 1,000 patients in each study.
Okay.
We
And
elected
was
to
there a duration of treatment that was also a criterion or
No,
not?
we did not specify that. We just went in and said the duration of treatment won't be an exclusion criteria. I thought the sample size, again, I sat down with my co-authors to discuss this. It was my proposal to say, let's exclude the one less than 1,000. I do not want to subject our analysis into type 1 error. And I'm sure people, if there's one or two events that could skew the whole thing. And I was like, we don't want that. We want actually a robust data. And that's why we have to exclude less than 1,000.
Great. And so what did you find?
So we had, So we had 11 randomized clinical trial. I think in total, the sample size of the patient included were 120,000 patients.
Oh, wow.
That was included. And we looked at the bleeding event. And what we tried to look at, we looked at all the bleeding events, regardless whether they are major or minor bleeding event. But we also specifically try to look at those which could be extremely worrying, not for patient, also but physician. Things like, intracranial bleed or hemorrhagic stroke and gastrointestinal bleeding. Those are really important. We need to ensure that there is an increased risk of bleeding in those particular patients. And from there, we were able to collect the data, and then we had to use RevMan, which is a statistical software, to look at the event rate of bleeding between patients who received omega-3 fatty acid and those who did not receive it, whether it was placebo or no placebo. So basically no treatment for those patients. And I could summarize the result for you, Bill, if that's what you're looking for now.
Sure.
Yeah.
Go for it.
Yeah. So basically, in summary, what we found is there was no increase in bleeding event in patients who received omega-3 fatty acid compared to those who did not receive it. And the rate ratio was 1.09. Definitely the p-value 0.34, so there's no difference.
Okay.
More importantly, the serious bleeding event, things like hemorrhagic stroke, intracranial bleeding, and gastrointestinal bleeding, was also similar between patients who received omega-3 fatty acid and those who did not. We also had a pre-specified analysis to reflect the use of Vascepa, icosapent ethyl, and we've done a specified analysis to look at those patients who received Vascepa compared to placebo. I think this will include 2 or 3 out of the 11 randomized clinical trial. What we've seen, there is an increase in bleeding in a relative risk, so by 50%. But what you look at as a physician is you want to look at what's the absolute risk of bleeding.
Right.
And this is very modest. It's less than 1%. In fact, when we quantified it, it was 0.6%. So it's a very small risk of bleeding. The third point, which we were definitely will try to look, and we could talk about why we had to do it, is I want to understand the increase in bleeding. Does it have to do with what the patient is on in terms of blood thinner? If the patient is on antiplatelet treatment, does that increase the bleeding risk when patients are on omega-3 fatty acid? And the conclusion actually that the proportion, the difference in bleeding between those who received omega-3 versus no omega-3 and who received antiplatelet treatment, there's actually no relationship. In fact, it will be probably a type 2 error here, but the relationship was actually the other way around. So if you are on more antiplatelet treatment, you are less likely to bleed. Obviously, the p-value was only 0.056, so it's not statistically significant, and therefore we can't draw a solid conclusion. But what we can say for sure, that being on antiplatelet therapy and omega-3 shouldn't increase with bleeding risk.
Wow, very interesting. Yeah, and that's I think been a story that's sort of been out there, been growing. Now you've got more and more data, but the worry about bleeding seems to be pretty pervasive. I mean, that idea got stuck in the minds of clinicians, particularly surgeons, I think, years ago, and it's been pretty hard to extricate it. What's your experience with having your colleagues or even yourself tell people that they need to stop their omega-3 before they go under the knife?
Well, I honestly, there shouldn't be any personal opinion here because there are randomized data on this. And randomized data tells me there's no increased bleeding risk. There's no procedural event. So it's not down to me now. The data tell me that you shouldn't stop it. Why you need to stop it? It doesn't add your risk of bleeding. So for me, and look, I'm not a surgeon. I'm an interventional cardiologist. I certainly wouldn't ask my patient to stop their omega-3 fatty acid before coming to have any intervention. This question actually came through one of my interventional colleagues because they said, well, I'm actually a bit reluctant. And that was like 18 months ago prior to the publication. And that's why it was factored in. I said, look, well, we have to demonstrate this on the data, using available data, that actually the risk does not increase when you do it on patient with antiplatelet treatment. Now, those with antithrombotic treatment, those on, like, let's say, warfarin or rivaroxaban or apixaban. Now the story might be different here. I think that needs to be taken on individual basis. What we're talking here about are patients who are on antiplatelet.
Yeah. We often hear people say, "I'm taking fish oil and I'm bruising a little more now." And what would you say that's increased bleeding?
Well, it depends on the patient response to it. So I'm not surprised if the patient is getting more bruises. There is, as I said, that means actually the fish oil is actually doing what it's supposed to do.
So it may be a good thing.
It's fine.
It is. It is thinning the blood, basically. And the same thing when people are on aspirin or people who are on dual antiplatelet treatment. They tell me in my clinic, I bruise a lot, doctors. And then you tell them, well, look, that means the blood thinners are working. And it's a balance between whether you want to continue that and get the benefit or stop this. That would stop the bruises, but you will lose the benefit. And this is, I think, the discussion would happen between the physician and the patient.
Yeah. So has all this experience changed your practice in terms of use of omega-3?
Yes. So by sure now, I'm more relaxed about giving patient omega-3 fatty acids after putting the stents. So if I think the patient will benefit from omega-3 fatty acid, and unfortunately the current instruction to use it is very limited, is very restricted, and I'm trying to, as we discussed, I don't think the triglyceride is the main driver here, which is the omega-3 being labeled before as a triglyceride lowering benefit or triglyceride lowering drug. I think the benefit is beyond this, but I am now very relaxed about putting people on omega-3 fatty acids, particularly obviously what I'm talking about is Vascepa, is after putting a stent, I don't have a problem. I will have a consultation with my patient. I will explain why we're doing it. I always say, look, there's a slight increased risk of bleed, but what we've seen from the data, it's actually not really with any interaction with the antiplatelets.
Yeah. So if patients are taking, go ahead.
No, go.
If patients come to you, I know they'll probably try and cut this out. If patients come to you on a dietary supplement of omega-3, how do you deal with that relative to instead of the pharmaceutical products?
Yeah, I wouldn't ask them to stop it. I wouldn't stop it. I would explain what I think because the supplementary one happening, they don't have the same robust data that we have from the pharmaceutical one, understandably.
Understandably.
Understandably. So basically what we have, that it's the high dose purified one that we've seen a significant benefit in patients with cardiovascular disease. Then you will argue that you could ask them, why you don't replace this with the pharmaceutical one and see whether, because we have a robust data on this. But would I stop it? I wouldn't go out of my way to ask them to stop it.
Yeah. Good. Great.
Yeah.
Interesting. So you have really been the latest one to call for some sanity around the omega-3 bleeding, because it's typically portrayed as an adverse event. Stay away from it. Be careful. And I think you and others have been saying, well, look at the data.
Well, it's not down to me to honestly, Bill. Look, I could here sit and speculate about what I think it is, but when people produce data, then it's difficult unless you produce data to counteract the argument.
Right.
I can't sit. What we practice more and more is evidence-based medicine. We don't practice personal-based or opinion-based medicine. I could say, this is what I think, but you'll be like, well, where's the data? How are you going to support your argument? And I initially was thinking that antiplatelet won't have maybe an effect or will have an effect. And I didn't know, actually. When you look at the data, you're like, well, there's a slight increase in bleeding. I thought, well, I can't have this argument all the time. I have to sit and, put a line through it. And that's what triggered actually the meta-analysis. And I thought we have to answer that question.
That's great. That's
great.
So
refreshing.
Yeah, it is.
I didn't know it's a big deal actually. Is that what's happening in the US? Currently, is it because in the UK I don't think it's the atrial fibrillation story. It happens. We've seen it, but the bleeding is less. That's my understanding.
Yeah, that's probably true. Right. So what's your has your appetite been whetted to explore this in more detail or explore other things about omega-3?
So yes. So I think what we should have is the next step basically is all the data currently. We've seen subgroup analyses and a small study looking at the introduction of omega-3 fatty acid early after event. And by event, I mean acute myocardial infarction. And what we've seen now from those subgroup analyses, and there's a smaller randomized trial, I think was conducted in Japan, but that was some time ago, showed actually mortality benefit, showed a reduction in death. Now, this is massive. And people were initially reluctant to start omega-3 fatty acids immediately after ACS because of the potential bleeding risk. Well, now we address this. The next step is, should we start omega-3 fatty acid immediately after acute coronary syndrome? And to answer this question, we need a proper randomized control trial to look at that.
Yes, right, exactly. And we've really not ever done that.
No, data from the
GC prevents, maybe.
Yeah, the reduced trial published some subgroup analysis on this to show actually the benefit is the magnitude of benefit is larger in those who had omega-3 fatty acid early after their acute myocardial infarction event.
Interesting. Yeah.
So it's the whole story starts to add up, but we just need the support to run the study and show actually does it help or does it not. I think that would be, then the data will talk. It's not me.
Yeah, that'd be great. More data is what we need. Well, I think Kristina, have you got any questions to close out here? I think we probably need to wrap up, but
I think you guys covered it. I just think it's interesting, the story, like you said, the bruising shows what omega-3s are supposed to be doing, but then that gets extrapolated. And so you think, oh, if there's a little bit more bleeding, then there must be a risk for a lot more bleeding. And it's just not the case. And so I do think it's kind of both. We get both. It is thinning blood. It is causing bleeding in that way. It's the right kind. It doesn't cause the severe events that we're actually worried about. So that conversation, I think, is difficult. And that's part of the communication that doctors and cardiologists will have to have with their patients. And so the data is fantastic, but also how do we communicate it very well? And I think this is, it's just really great to hear it from the cardiologist community that this is not the big issue.
No, this is one element, beyond lipid lowering treatment, beyond antiplatelet treatment, we think there's another effect, things like, as I said, plaque stabilization, anti-inflammation. We just need to dig into and understand a bit more about it rather than being skeptics. The data is the data. No one's quoting data. This is what it is. If you don't understand it, well, you go back and dig more. Because I honestly, initially, I was skeptic when things came out. And I was very skeptical about it. But I thought, you know what? I can't just sit and criticize without supporting my argument. I have to go back. And when I went back and I read about it, and I was like, well, hang on. I think I was missing something.
That's great.
We'll let you have the last word on that. That's very good. Thank you so much for your time, Mohammed. Very
Thanks very much for having me.
Our pleasure. Our pleasure.
Mhm.
And we'll let you go, and folks, be ready for another Omega Matters interview coming up soon. The topic to be discussed.
Thank
Thanks
you.
very much.
Thank you very much, guys.
Yeah.
Bye-bye.
Bye.
Bye.